Hi everyone, I hope you're all staying safe. This is my presentation of the final exam for our pediatric sonography class. So the objectives of this video is to just discuss some pathology that we've learned throughout this course, and those include the brain, spine, abdomen, bowel, neck, hip, chest, kidneys, bladder, and male and female reproductive tracts. So starting with the brain. The first abnormality of the brain that we're going to talk about is Dandy-Walker malformation, and this is a congenital anomaly resulting from the disturbance of growth in the roof of the fourth ventricle and cerebellum. So this causes a cystic dilatation of the fourth ventricle with association with dilatation of the third and lateral ventricles. So what you're going to see on a scan is cystic dilatation of the fourth ventricle. That's going to communicate with the cisterna magnum, a large posterior fossa, complete or partial absence of the vermis, hypoplastic cerebellum displaced laterally, an upward displacement of the tentorium, and dilatation of the third and lateral ventricles. And in this picture, you can see right here is the third ventricle, and it's very dilated. There's no corpus callosum. Right there's some chorioid plexus. And then down here, there's no vermis, dilatation of the fourth ventricle, and displacement of the cerebellar hemisphere. The next brain abnormality is schizencephaly, and this is the failure of migration of cells which were to form the cerebral cortex, and that is caused by the cytomegalovirus. This presents as cleft lines with gray matter that extend from the lateral ventricle through the hemisphere to the cortex. Some signs and symptoms, clinical signs and symptoms, are seizures, hemiparesis, developmental delay, and blindness. On ultrasound, we'll see unilateral or bilateral cystic cleft communication with the ventricular system, cystic cavities of varying sizes, and possibly associated with agenesis of the corpus callosum. So if we look over here at this picture, we can see here's a lateral ventricle, and this is the whole cystic communication between the ventricles, and that's not supposed to be there. The last brain abnormality is aqueductal stenosis, and this is the most common form of obstructive hydrocephalus, and this is caused by the narrowing of the aqueduct of Sylvius, and that's the communication of the third and fourth ventricle. It's usually congenital, but it may be caused by infection, hemorrhage, compression, or tumor. The ultrasound findings that we will see is dilatation and widening of the lateral and third ventricles, but the fourth ventricle will be normal. And on this picture, you can see all this dilation, dilatation. Here's the third ventricle, and then here is the normal fourth ventricle. Moving on to spine. The first spinal abnormality we're going to talk about is the tethered cord. And this is when the spinal cord becomes attached to the spinal column, and that restricts the movement of the spinal cord. And this abnormally stretches the spinal cord and is often associated with spina bifida. Some clinical signs and symptoms are weakness in the legs, lower back pain, scoliosis, loss of bladder and bowel control. There's a hair tuft, and atypical sacral dimples, and we know that the last two signs and symptoms are associated with spina bifida. The ultrasound findings, you're going to see the conus medullaris extending below the first and second lumbar vertebrae. The cord is fixed to the posterior wall. There's absent cord oscillations, and there's going to be a thickened filum terminal. So you can see here that it's extending way past the L1 and L2, in how inflamed and thickened the filum terminale is. The next spinal abnormality I will be discussing is the myelomeningocele, and this is a congenital defect in which the dorsal aspect of the neural tube fails to close, and this results in the herniation of the spinal cord and meninges. That's both spinal cord and meninges. And this can usually be surgically repaired within a few days of birth. Some clinical signs and symptoms: there's neural tissue herniation that is identified at birth. So it's like a big mess on the spine that's visible. And this is usually located below L12, but can be cervical or thoracic in position. Some ultrasound findings: we're going to see a tethered cord, and that, like we just discussed, is going to be below the L1 and L2 level. The spinal cord possibly herniating through the dura, which is a skin defect, and that's going to have a membranous covering like I mentioned before. And then nerve roots possibly identified in the sac, and this is demonstrating pulsation on real time, unlike fibrous strands. Those you can see moving with like the movement of the cord, but this is going to be like an arterial pulsation. Next is a meningocele, which is different than a myelomeningocele. This is also a congenital defect where the dorsal aspect of the neural tube fails to close, and this is resulting in herniation of the spinal meninges only, no cord. So no neural tissue is involved in this herniation. Some signs and symptoms clinically is a visible cystic mass on the posterior aspect of the spine, which would be identified at birth. And it's usually located below L2, but can be cervical or thoracic in position like a myelomeningocele. So ultrasound findings: there's going to be a tethered cord, and we know that the conus is below L1 and L2. You're also going to be able to see an anechoic lesion herniating through the dura, and that's going to have a defect. That's a skin defect with a membrane covering. And there's anechoic lesion communicates with the spinal cord. So basically what's differentiating between a myelomeningocele and a meningocele is the contents in the herniation. Moving on to the abdomen. The first abdominal abnormality that I will be talking about is a hypertrophic pyloric stenosis, and this is the gastrointestinal disorder in which the circular pyloric muscle becomes thickened, causing narrowing of the pyloric canal. This usually appears in children between 2 and 6 weeks, but it can be detected at birth or after 6 weeks. But usually you don't see them after 5 months. And HPS is 4 times more often found in males and females. Some lab findings can be a hypochloremic, hypoalkalemic, metabolic alkalosis, possibly some hypernatremia or hypo or hyperatremia, and that's the result of dehydration, possibly elevated unconjugated bilirubin levels, and that's not listed here, but that's just something to think about. Some clinical signs and symptoms: projectile vomiting, dehydration, weight loss, palpable or olive-shaped upper abdominal mass. Some ultrasound findings: there's the cervix sign. Pyloric muscle thickness is greater than 3.5 millimeters. The pyloric muscle length is greater than 20 millimeters. The pyloric canal length is greater than 17 millimeters, and there's retrograde fluid or fluid movement, so it's going back up, which is the vomiting. Lack of passage of fluid, the lack of passage of fluid through the pyloric canal, exaggerated gastric peristaltic movement, failure of relaxation and opening of the pylorus, and delayed gastric emptying. So when I meant by cervical sign, you can see here. or the cervix sign, right there. And you can tell how inflamed and thickened the muscle is and how elongated the pyloric canal is. If you look at these, you can see that it is greater than 20 millimeters. The next one is appendicitis, and this is the inflammation of the appendix caused by obstruction of its lumen and subsequent bacterial invasion. This is the second most common cause of acute abdominal inflammation in children. Some clinical signs and symptoms are acute abdominal pain in the lower right quadrant, the McBurney sign, nausea, vomiting, and fever. Some lab findings is leukocytosis, which is an increase of white blood cell count, and there might be a urinalysis to indicate a few white or red blood cells. Some ultrasound findings, the appendix is blind-ended or blunt-ended, and it lacks peristalsis, and it's located in the right lower quadrant. It has an anechoic or hypoechoic filled lumen, which is an echogenic mucosa lining with an echogenic mucosa lining the inner wall and a hypoechoic muscle wall surrounding the mucosa. This gives it a bullseye appearance in the transverse view. The inflamed appendix is non-compressible. The diameter is greater than 6 millimeters. The inflamed appendix causes local pain when the transducer is over it. There's a hypervascular wall with color Doppler. There could be appendicoliths casting some shadows, and there may be a reduced peristalsis in the adjacent intestinal loop. Moving on to bowel. Intussusception, this is the first bowel abnormality. This is one part of the bowel invaginates into the lumen of the adjacent part of the bowel. This causes obstruction which can result in necrosis and consequent bowel perforation. Some signs and symptoms are colicky, abdominal pain, vomiting, abnormal or bloody, current, jelly stools, or an abdominal mass. The sonographic findings is the donut sign, and this is visible in the short axis or transverse view. The sandwich sign is visible in the long axis view. There's an edematous obstructed bowel may occur proximal to the intussusception. There may be free peritoneal fluid, and that's a large amount. A large amount implies an extensive edematous bowel and possibly bowel infarction. The intestinal wall may be hypovascular, suggesting bowel infarction, and the mesentery may be hypervascular. The small bowel obstruction is the next one. Proximal bowel loops will become fluid-filled and dilated and hyperperistolic, and this can be congenital or mechanical. Congenital is just intestinal perforation can occur, and as a consequence, meconium will leak into the peritoneal cavity. Mechanical is classified according to location and the cause of the blockage. So there's intraluminal, intramural, or extrinsic. This pathology is known as meconium ileus and is associated with cystic fibrosis. Some clinical signs and symptoms as abdominal pain, constipation, failure to pass meconium in the first 12 to 24 hours after birth, fever, nausea, vomiting, hypoactive or absent bowel sounds. Some sonographic findings: the small bowel is distended with air and fluid. There may be remnants of fetal meconium leakage, and that's visible as scattered calcifications in the peritoneal cavity. Cystic meconium peritonitis is possible. Intestinal hematomas are possible, and there may be a mass if this is the cause of the obstruction. And then malrotation, and this is non-rotation or incomplete rotation of the intestines during fetal development. And so the mesenteric fixation of the bowel to the posterior abdominal wall is not complete. Clinical signs and symptoms, there's acute abdominal pain, abdominal distension, bilious vomiting, and then blood from the rectum or blood in stool. Some findings sonographically are generally the duodenal jejunal flexure appears lower and is more medial than normal. The small bowel has a corkscrew appearance. The proximal duodenum is filled and dilated with distal tapering. There's strong peristaltic movement, and it's evident in the obstructive duodenum. The mesenteric vessels are abnormally positioned. So the superior mesenteric vein is located anterior or left of the superior mesenteric artery. And then there's a whirlpool sign, and that can be visualized with color Doppler. Moving on to the neck. So the first neck abnormality is scoliothiasis, and this is the most common submandibular. On the US or the ultrasound findings is a hyperechoic foci with shadowing, and you can see this foci right here within the neck. The next one is fibromatosis coli, and this is a soft tissue. It's found in soft tissue around 2 to 8 weeks after birth, and the findings are an ipsilateral head tilt, contralateral tin deviation, and an enlargement of the SEM muscle. It's a big guy. Lastly is a pilomatricoma, and this arises from hair follicles, and this nodule attaches to the skin and is mobile. It's well-defined hypoechoic. It may contain calcifications and has a hypoechoic rim. Moving on to the hip. The first hip abnormality is developmental dysplasia of the hip, or DDH, and this is a broad term to describe a spectrum of conditions where an inadequately formed antecebulum results in instability, subluxation, or dislocation of the hip. Usually the treatment of this, if it's found early, is immobilization, or if you find it later, there's going to be surgical intervention. Some risk factors of this is there's a family history. It could be because it's a firstborn child from a first-time mom. Breech delivery. There is oligohydramnios in utero. There's foot deformities or congenital torticollis, which is when the baby keeps his head right or left, and so they have a head tilt. Some signs and symptoms, it's not detected in unilateral. Okay, so some signs and symptoms, if it's not detected and is unilateral, they may have a limp. If it's not detected and it's bilateral, they're going to have a waddling gait. So this is asymmetrical leg creases, unequal leg lengths, limited leg abduction, and abnormal ligamentous laxity of the hips. So if you look at the pictures over here, you can see that here's the hip right here, and it's formed completely, but it's just dislocated posterior and superiorly. And you can see the labrum right here, between the antecellum and the femoral head, and here is a flat antecellum. I don't know if you can see this one very well, but you can just tell that it's not in place because here's the roof of the cartilage and it's not completely uh, the femur isn't completely covered by that. You can't really see that because I'm in the way. Next is a hip effusion, and this is abnormal increase of synovial fluid within the hip joint, and it's commonly caused by a transient synoviitis. Signs and symptoms is hip pain, walking with a limp, reduction in the hip movement, especially external rotation. There might be an afebrile or mild or high fever. Some ultrasound findings is a fluid-filled anterior recess of capsule with anechoic appearance. This capsule at the anterior recess measures greater than 5 millimeters in thickness. Anterior recess appears convex in configuration due to fluid distension of the recess. And there's possible echoes in the fluid, and that can be the presence of hemorrhage or debris. Moving on to chest. A pleural effusion. This is a dependent collection posteriorly and caudal. The lung floats on top, posterior to the chest wall, and is visualized behind the fluid. Some ultrasound findings is free fluid moves with respiration, the diaphragm sign or displaced cruise sign, and bare area sign. So you can just see, here's the diaphragm, and here's the liver, and the bare area sign is that you can actually see this part of the liver. It's usually hard to get. You can actually see lung, and this is just all the tissue, or not tissue, all the fluid within the cavity. Exudates, this is a complex collection of pleural effusions, and it's the honeycomb appearance that you see here. That can be caused by hemorrhage or infection. Lastly is diaphragmatic paralysis, and this is the absence or paradoxal motion on one side and exaggerated excursions on the opposite side of the lungs. This can be a concern after cardiac surgery, and M mode is used to assess. And normal findings, as you can see, you should be able to see movement with breath of the diaphragm, and it should look like, you can't really see it, but there's movement. You can tell that there's movement right there. It's not just stagnate. Moving on to kidneys. First is an ectopic ureter, and this is an abnormal insertion of the ureter into the bladder, and the ureter can bypass the bladder and connect directly to the urethra, vagina, seminal vesicles, or ejaculatory ducts. Some signs and symptoms are UTI or incontinence. The sonographic findings, the ureter connecting with an organ other than the bladder, or there's a low-lying distal ureter not inserting into the inferior posterior aspect of the bladder. So they should be connecting down here at the posterior part. And you can see that it's not posterior, it's connecting right there. Ureteral obstruction. This is due to compression by an external mass, such as an abscess or lymphoma. However, obstruction occurs more often inside the ureter due to presence of stones, blood clots, or fungus. Some clinical signs and symptoms are flank pain, lower abdominal pain, hematuria, abnormally colored urine, fever, vomiting, or nausea. Some sonographic findings, there's hydronephrosis, a hydroureter with a narrow distal ureter behind the bladder, and that's a UVJ obstruction. It should be UVJ. The hydroureter with a sudden abruption and with with a possible distal lesion is present. Increased peristalsis in the proximal ureter and reduced or abnormal ureteral jet visualized with Doppler. Next is prune belly syndrome, and this is a rare congenital syndrome that involves anomalies of the genitals and urinary system and the absence or deficiency of abdominal musculature. So that's usually associated with bladder outlet obstruction, and it's usually caught in ureto. And basically, no urine is coming out of baby, so all of this urine is getting stuck, and then I think the bladder, it eventually will rupture if it's not caught. So clinical signs and symptoms are a wrinkled prune-like abdomen, there's an enlarged abdomen, small thorax, undescended testicles, and a hip dislocation. Sonographic findings is a dilated bladder with poor contractility, dysplastic echogenic kidneys, hydronephrosis, a megaureter, or cryptorganism. Moving on to bladder. Bladder outlet obstruction. I talked about that a little bit before. It's the most common cause of obstruction it's the most common cause of obstruction in the abnormal presence of a posterior urethral valve in males. So this is the most common in males. Clinical signs and symptoms is a palpable kidneys or bladder in neonates, palpable kidneys in older children, flank pain, absence or decreased urine output, urinary tract infection, renal failure, hematuria, or fever. Ultrasound findings, a thickened irregular bladder wall, distended bladder, keyhole appearance of the bladder and urethra, bilateral hydronephrosis, bilateral hydroureter, distended posterior urethra when posterior urethral valves are present, possible urinary ascites, possible anechoic perirenal urinoma, which may contain septations, and a variable residual volume seen post microturbation. A ureteral seal. This is abnormal dilatation of internal segment of the ureter wall at the level of the vesico-ureteral junction. Clinical signs and symptoms is a palpable mass, urinary retention, a UTI, or urinary incontinence. Sonographic findings is an anechoic fluid mass within the urinary bladder with a thin septation. This is located inframedially to the ureteral insertion when the lower pole ureter is dilated. Ipsilateral dilatation or dilated kidney and dilated proximal ureter, continuous with dilated distal ureter and ureteral sill. Possible distension, color Doppler will possibly show urine flow through the thin membrane into the bladder. Exstrophy of the bladder is the last bladder abnormality, and this is a rare congenital anomaly which results from a defect in development. In most cases, exstrophy can be directly identified prenatally, or it will be obvious at delivery because the bladder is completely outside of the body. Some signs and symptoms is lower abdominal wall mass with bladder or urethra mucosa exposed, low set umbilical cord, abnormal genitalia, increased pelvic diameter, pelvic bones are widely separated. Some findings, repeated failure to visualize bladder. This is within when you're scanning baby inside mom. So there's hydronephrosis, hydroureter, possible ectopic pelvic kidney, and possible renal agenesis. So moving on to the female genitalia tract. So one abnormality is fibroids. This is the most common cause of enlargement of non-pregnant uteruses. Some signs and symptoms, they could be asymptomatic. There's menorrhagia, metorrhagia, anemia, and urinary frequency. Some findings sonographically can be contour distortion of uterine wall, internal calcification and or cystic degeneration in fluid levels, or irregular outer walls of uterus due to subserosis fibroid. So as you can see here in this picture, you see this mass, and that is a fibroid. Next is an arteriovenous malformation, and this is rare in the uterus, but it's a direct communication between arteries and veins, and this is usually congenital. Signs and symptoms may be metorrhagia with blood loss and anemia. Some findings sonographically could be an intramural uterine, endometrial or cervical mass, color Doppler flow within the anechoic structure with a pattern, some mosaic pattern with aliasing, and there's just a chaotic color flow appearing. You can see it right there. There really shouldn't be that much flow found within the uterus, but you can see that that's a AV formation. Lastly is a Nabathian cyst, otherwise known as an epithelial inclusion cyst or Nabathian follicles. And this is a mucus-filled cervical cysts that are considered harmless. They can cause benign enlargement of the cervix, however. These signs and symptoms there's usually none. It's typically incidental when scanning the pelvis and the uterus. Some sonographic findings is they could be a variable size from a few millimeters up to 4 centimeters. They can be single or multiple. They can be discrete round anechoic, or they are discrete round anechoic cystic structures. They may have internal echoes from hemorrhage or infection. Lastly, the male genitalia tract. So the first abnormality could be epididymitis, and in most cases, it's a cause of infection. And the epididymis is the first scrotal organ to be affected, causing the epididymitis. The inflammation will cause further congestion and scrotal swelling if not treated. Some signs and symptoms are initial abdominal flank or groin pain, mild or severe scrotal pain, which increases over 1 to 2 days, scrotal swelling, fever, or urethral discharge. Some sonographic findings are hypoechoic epididymis with there could be calcifications if it's chronic. An enlarged epididymis. There's increased blood flow to the epididymis. So there could be small cysts, scrotal wall thickening, or a hydrocele. So rupture. This is the testicular contents extrude into the scrotal sac, and this can be caused by trauma. Signs and symptoms, if it's acute and severe scrotal pain, and you may be able to feel palpate a scrotal mass. Some sonographic findings is an irregular testicular contour, focal alteration in echogenicity, extrusion of the testes into the scrotal sac, and a hematocele, which is basically a blood clot or blood around the testicles within the sac. Lastly is torsion. And this is the abnormal movement of the testes within the scrotum that causes the twisting of the spermatic cord. And there's an interruption, and it will interrupt its vascular supply. So this is a pretty big deal. So you want to be able to find it if you find it within 5 to 6 hours and have surgery, it usually saves about 80 to 100% of the testes. If you don't find it after 6 hours, it's a 70% chance to have save the testicle, but after 12 hours, it's very hard to save the testicle. There's a 20% chance. Some signs and symptoms: acute and severe groin scrotal pain, lower abdominal pain, nausea, vomiting, and scrotal swelling. And actually, they say that it's severe pain at night. So it's a lot of an ER visit. Men will come in saying that they have a severe testicular pain just waking up in the middle of the night. Sonographic findings: there's testicular blood flow that is absent or decreased. There could be a hydrocele. There could be scrotal skin thickening, and a twist may be visible as a round or oval extratesticular mass. So you can see in the image here that you can see the spermatic cord with color, that's without color, and you can see that there's absolutely no blood flow within the testicle. And it must be getting bad because here's some that looks like an infarction. So these are my references. Thank you for listening, and I hope you guys have a good rest of your finals week. Thank you.